Good evening, everyone, and welcome to No Pain, No Gain. Beyond medications, effective treatments for the most common and complex chronic pain conditions, the second in our four-part series. My name is Prabjit, or many of you may already know me as Prab. I'm a shared care project manager here at the Surrey-North Delta Division of Family Practice. I'm delighted to welcome you all here tonight. Before we begin, I want to gratefully and respectfully acknowledge the opportunity for us to conduct this project work on the ancestral and traditional territory of the Coast Salish people, specifically the Kwantlen, Samiamu, Tawasin, Katsi, Coquitlam, Kaikwiet, and numerous other Stolo First Nations. We want to support culturally safe care for our First Nations, Inuit, and Métis community members. The No Pain, No Gain series was developed by our Chronic Pain Working Group, which features family physicians, specialists, the Surrey-North Delta PCN, representatives from Fraser Health, as well as Pain Care BC. We're bringing you all here together to learn, collaborate, and build a more connected pain care approach. We have an exciting evening planned tonight featuring presentations, case studies, and Q&As by Jennifer Lay and Julia Ottbitter from Fraser Health. Jennifer is an experienced occupational therapist with 7 years of experience at the Fraser Health Pain Self-Management Program. She currently serves as the regional pain lead, advancing strategic initiatives to improve pain care and support both patients and clinicians across the region. She holds a master's certificate in pain management from the University of Alberta and has completed extensive training in areas such as CBTI, acceptance and commitment therapy, and pain reprocessing therapy. A committed educator and clinician, she leads initiatives that build capacity, strengthen collaboration, and make pain care more accessible. Her trauma-informed approach emphasizes clear communication, strong relationships, and equitable and integrated services. Julia is a registered nurse and clinical coordinator at the Fraser Health Pain Self-Management Clinic with over a decade of experience and leadership across acute and community care settings. She champions clinical and system-level innovations in trauma-informed and strength-based care. She holds dual degrees in nursing and psychology from UBC and is a certified holistic nurse coach and consultant with additional training in pain reprocessing therapy. She founded Safe Space Healing, a private practice integrating holistic, evidence-informed approaches to pain, stress, and burnout, and she's a member of the Association for the Treatment of Neuropathic Symptoms and participates in grant-funded research on implementing the biopsychosocial model of pain. Just a few quick housekeeping notes before we begin. We have our washrooms located at the back right, and as you were entering, you may have noticed a photography consent notice at the registration table. This event will be photographed, and if you do not wish to be photographed, please let Gervine or any other division staff member know. During dinner, you also may have noticed the rotating slide deck. In case you missed that, we have paper versions of those resources at our resource table at the back. You're also welcome to take pictures of the slides or any presentations or case studies, but just remember we will be sharing the slide deck as part of our post-event summary, so no worries about that. And at the end of the session, we'll distribute paper copies of our evaluation and also display a QR code if you prefer to just complete it on your phone. Please ensure you complete those. They are anonymous, and we'll need your information to ensure sessional payment. During the presentations, you'll have the opportunity to input your questions on the Slido QR codes that are on your table, the blue QR codes. You can input those questions throughout the presentation, but we will be answering all of them at the end during the Q&A portion of the night. If there's a question that you like, you can thumbs up and it will come to the top of our Slido panel.
Thank you so much for being here, and we're really excited to share some information with you. And before we get started, we just thought it might be nice to settle in and do a little bit of a breathing exercise. So we're going to play a short breathing exercise, and if you feel comfortable, you can do that with us.
Hi, and welcome to Headspace. So no matter what's going on in your life right now, no matter how many thoughts are racing around your mind, no matter how the body's feeling, just take a moment to sit down and take a big deep breath, breathing in through the nose and out through the mouth. As you breathe in, a sense of taking in fresh air, the lungs expanding. As you breathe out, a sense of letting go of any stress in the body, in the mind, just feeling the muscles soften and relax. And close your eyes if you'd like to. One more. Breathing deeply in through the nose and out through the mouth. And just take a moment to pause. Allow the thoughts to come and go. And then just gently opening the eyes again.
So just as a reminder, this is session 2 of a 4-part series. And in session 3, just so that we know what's up ahead, we're going to be talking about collaborative approaches to pain care. We're going to have some conversation about interventional pain strategies, as well as an Indigenous knowledge keeper to talk about that lens as well. In session 4, we're going to have a talk on safe prescribing and sustaining care. And we'll have a conversation about opioid stewardship, how to mitigate some risk, and other pharmacological options. We'll also be talking about sustaining care over time, which can include flare planning, supporting safer coping, and preventing clinician burnout. So for today's agenda, Julia and I are going to be talking about pain, right? What is pain? We'll talk about some descriptors of pain. And we want to do this in a way that you can help your patients understand that a little bit better as well. We're going to explain why it matters for practice and patient experiences, and we'll also offer some practical communication skills and strategies that you can utilize right away. And then after, we're going to ask Dr. Gary Palick to come up here and be in a panel with us to answer some questions that you have. All right. So I just wanted to get started with some historical milestones around pain theory. So over the years, the pain theories have changed, right? So in ancient times, pain might have been seen as a divine punishment or spiritual affliction. In the 17th century, we have Descartes, which proposed that pain was a signal sent from the site of injury to the brain. And then in the 19th century, we learned about nociceptors and their role in transmitting pain signals to the nervous system. Then in 1965, we had the gate control theory, and we thought that pain signals were modulated at the spinal cord, right, from non-painful input like touch or movement, and different things can open and close those gates. More recently, we've had the neuromatrix theory, also from Malzak in the 1990s, which is continued to be expanded on. And this really framework helps us to realize that pain is an output of the brain, right? So our pain is shaped by sensory input, emotions, thoughts, and past experiences. And it's not just about tissue damage. And we want to highlight that pain theories have changed over time, and so our treatment of pain should also change with those theories. And as we have a deeper understanding, we're going to be able to share this information with our patients and show them that their treatment or their models of pain should change as well, right? So this shift really matters to help patients understand that pain is more than tissue damage, right? And when they understand that, they can feel less blamed, less dismissed, less fearful if pain persists. And a modern understanding of pain helps patients make sense of their pain right? It reduces the fear and distress that they're feeling and can help them feel more confident in movement and daily activities. So we know that treating patients with prolonged rest and passive treatments and a really biomedical focus isn't effective. Current evidence supports that the shift in practice towards more active, person-centered approaches that reflect our growing understanding of pain can lead to better patient outcomes. Oh, yeah. Okay, so what is pain? So we have a descriptor here. So it says pain is whatever a person says it is and exists whenever a person says it does. So what do we think about that? Yeah. It's subjective, right? And it works well with the second line where it says it's personal, private, and unique to each person, right? So our experience of pain can be really different even if we have the same pain condition. Even if I rate my pain 5 out of 10 and Julia rates her pain 5 out of 10, doesn't mean that we're experiencing it in the same way, right? So that's really important to understand and validate for the patient. And then we have a more formal definition where it says, pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So we can break that down, right? It's something that's unpleasant, we'd agree? Yeah, something that we feel. And there's an emotional experience with it, right? That could be fear, sadness, frustration, and it can be associated with actual or potential tissue damage, right? So there doesn't have to be tissue damage for us to experience pain, right? And I think sometimes patients don't understand that, right? We also have some descriptors of stages of pain, right? So we have acute pain, so that's less than 4 weeks and occurs within the context of tissue damage and repair, resolving with tissue healing, right? This is what most people are familiar with. We've sprained an ankle, we've broken a bone. Then we have acute pain or transitional pain. So that's pain that isn't resolving or diminishing as expected in the 4 to 12 weeks after initial onset. So this time frame should prompt practitioners to pause and reflect on the effectiveness of current pain management strategies and consider early intervention to reduce the risk of pain becoming chronic, right? We can have these conversations with our patients as well. You know, I'm kind of concerned because things aren't progressing as it normally should, right? And then if anything lasts for greater than 3 months, that can be referred to as chronic pain. So chronic pain or persistent pain is pain that lasts longer than 3 months. It may arise from long-term medical conditions that are not expected to fully resolve, such as osteoarthritis, scoliosis, or multiple sclerosis, or it may persist beyond the expected time of tissue healing. There are 3 different main types of pain, and we have them here. We have nociceptive pain, neuropathic pain, and nociplastic pain. So nociceptive pain is probably what most are familiar with, right? It comes with actual or threatened damage, such as muscle, joints, or organs, and it occurs when nociceptors are activated by injury or inflammation and is often described as sharp, throbbing, and examples include sprains, fractures, arthritis flares, and post-surgical pain. We then also have neuropathic pain, which is caused by injury or disease to the nervous system. And damaged nerves send abnormal signals to the brain, resulting in sensations such as burning, shooting, buzzing, numbness, or tingling. So examples of this include diabetic neuropathy, sciatica, carpal tunnel, or post-herpetic neuralgia. And then we have nociplastic pain, or also known as neuroplastic pain. This arises from altered pain processing where the nervous system becomes more sensitive without clear tissue damage or nerve injury. This increased sensitivity is often referred to as central sensitization and means the brain and spinal cord can amplify normal signals or produce pain even in the absence of ongoing injury. So examples of this can be fibromyalgia, chronic low back pain, or pain without a structural cause, such as chronic headaches or irritable bowel syndrome. So I just wanted to point out that most patients might be aware of that nociceptive pain and think that treatment should be in line with that. So we just wanted to bring this up to highlight that we can have mixed pains, and if pain is neuropathic or nociplastic, we might want to bring that on, that might want to educate the patient so that they can change their framework around how pain is being treated. Okay, so why do we have pain? Is it good? Is it bad? Any ideas from the crowd? Yeah, I heard protection. I heard it's good.
Or also, how would our patients answer that question?
Yeah, it's a good question.
What do they think? Why they have pain? Yeah. All right, I'll jump in then, and I'll take that. My name is Julia. I think you might have seen that Jen was originally going to be presenting with Kat, but she was unwell. So I'm popping in today and filling in, and just found out today. So we'll see how the notes and everything flows. But I heard the answer already, thankfully, on why do we have pain. And this is idea around protection, right? And it is a system that is learning and acting really fast. So we see this picture of a cook near a hot flame, and if they were to get too close to the flame and burn the hand, right, that hand is going to fly off away from the fire so fast before you're even consciously thinking about it. It's just protecting you from what the body senses would be a big problem if you had kept your hand there. So it's predicting and making changes. And it's learning as well. So if we're a chef and we've burned our hands a few times, then that system of protection is going to click on even faster. Right? So it's an adaptive, protective machine or system. Lots of buttons here. Okay, how does it do this? We know kind of the nociceptors, or the specialized sensors in the body, those that are responsible for the health and well-being of different parts of our body, are going to be detecting harmful stimuli. And this is a message that we've actually taken right from one of our most popular slides in the Fraser Health Community Pain Self-Management Program, and helping patients to see that there isn't actually a pain signal that's going, right? These cells are detecting changes in mechanical pressure or touch, thermal changes such as heat or cold, or chemical like inflammation. And so when the cells that are responsible for the safety of that body part detect a change, they're going to send action potential up through the neuro relay system, and it's not actually experienced as pain until it reaches the brain, right? And the brain will process these messages to determine what kind of experience we need to be having. So again, that is a message that's helpful for patients to know, and that the amount or the tolerance that those cells will tolerate can change over time. Just like we talked about on the previous slide with the chef whose hand was close to the fire and got burned several times, it learned to really avoid that flame. All the way down to the cellular level, they're learning, that we can tolerate some of these changes less and less, and then it just takes me going barely close to the fire, and that change in temperature has already got my protective system clicking on. So it's a little animation of it. So as these warning messages arrive from the body up into the brain isn't just a passive receiver of the information, right? It's going to be filtering the information to do that piece that we just talked about on the predicting. And it's going to make a prediction, and that's deciding how threatening is this signal, and how much do I need you to consciously be aware of this signal or this sensation in the body. And it's going to make that decision based on a few factors. Past events that have happened. Again, we've talked about that. Are there other underlying conditions that are going on? If I sprained my ankle and I was walking more and my ankle felt sore, it'll take those sensations a little bit differently than if I had just overwalked without a sprained ankle. If I was dehydrated and I had done a bunch of stretching. So there's, the overall picture of tissue health is looked at in conjunction with those signals being experienced, as well as, psychological factors. How stressed am I? How tense and on edge? Or how many of those stress hormones are going through my body? My mood level as well, and how that affects those stress hormones. What do I think about this pain, right? If I have a migraine and I'm thinking to myself, oh my gosh, I can't handle this is killing me, those thoughts are going to also be putting the threat detection system on heightened alert. My social environment, do I have people that can help me when I'm in bed from a migraine? Do I have a trusted healthcare provider? What did it look like when my mom had these kind of pain experiences when I was growing up? So those past memories, and again, like even social learning. We can think of this as nociception that's going into a dial of how much danger am I in, how much safety do I have, and that's going to help influence how the brain interprets those signals. And so Lorimer Mosley, a physiotherapist and researcher, talks a lot about this and really has broken down a lot of great resources at the patient level to explain these ideas. And one of those is the danger in me and the Sims in me. I'm not sure if we've heard of that before, DIMS and Sims. There is a handout on the tables for everybody that you can see that you can even use with patients. Do we want to do questions now or at the end? How is that working? Sure.
Are those unconscious thoughts that you are talking about?
Great question. So she's asking, are all those filters that the brain is using to decide the threat level, are they conscious or not conscious? Any guesses? A mix? Could be a mix. Probably mostly a lot of it's subconscious, right? When I have my migraine, let's say, I don't necessarily right away think about my family member or my work stress or the fact that I didn't drink all day. I might not even be conscious that I'm thinking the thought, gosh, this is killing me. I'm just like stuck in it, right? So yeah, it's kind of a mix of both. But what we can do, that was a great segue, I don't know if you were planted there for this, but is this handout, which is the DIMS and SIMS. And that is where folks can look at, what are the things that put my body in a more threatened or heightened hypervigilant state. Kind of a triggered state. It doesn't have to be a state that triggers my pain, but just like what puts me more in a tense and worried state. What are the things that help me to feel more safe and grounded and empowered and calm and resilient? And he's broken it down into a few categories, things that I can tactily in my environment use or experience. What can I be doing, saying? Reframing, thinking to myself, places that I could go, sensations in the body, right? So that's a handout that you might find helpful. We can do a little activity. If anybody wants to stand up to get a bit of a stretch, or you can just put your hands up, let me know which of these you would consider to be a dim or kind of a danger or something that would put you on edge, feeling tense. Cuddling with an animal. How about cuddling with a cat? Safety for some people, maybe danger for some if you have an allergy or a fear of cats that's out there. How about being out in nature? Okay, yes, some are, yep, absolutely. How about going to Costco? Talking on the phone with a supportive friend. Sim, yeah. How about public speaking? Dim for some, like straight out. Going to the dentist? Dim, I hear that. I better call my dentist. Going to a party? Sim. We have some social ones out there. Okay. So yeah, you can see, there are some experiences that are universal, some of it's really individualized. And so we as care providers can't even always tell, like, what are the things that's going on in a person's life that's making them stressed and feel overwhelmed. But just to let them self-reflect on it can be helpful. And we at the Pain Self-Management Program love analogies. This is another slide that's kind of taken from our program, describing this as like a pain alarm system, right? So it can warn us that we need protection, but a fire alarm, kind of can go off when there's a fire, but can it go off when there isn't a fire? Yes, yeah. Does it always tell us how big of a fire it is? Or if it's like just smoke from burning something, right? If we know that the fire alarm is going off, do we always know what exactly we should do to be putting it out? Or that the alarm system might be becoming more sensitized? That alarm system might be like a dog, a pet, a dog that barks when somebody's at the door, and they can just get more anxious over time and then start barking whenever anybody is even going past the window. Right, so these warning systems are not exactly a damage detecting system. It's just there to give us information and a way of the body communicating with us that there's something that's going awry. But really what Jen was talking about in terms of our modern understanding of pain is that the damage detecting system, maybe had been the old way of viewing this system. But now we're understanding it's warning us that something is going awry in the body, but what is that? And we're really looking at it through a more holistic lens of what the body's trying to communicate with us is going wrong. And it's not always like what's happening at the tissue level. It's maybe some of those other filters that we had talked about with the brain, looking at what's a threat or not. So we're just going to look through some of the key messages about pain. In 2020, the IASP added 6 key messages to the definition of pain that Jen had read. Just to clarify, how should pain be understood and addressed in modern clinical practice? But before we do that, we'll just look at a little video. And I will, perfect.
In 1995, the British Medical Journal published an astonishing report about a 29-year-old builder. He accidentally jumped onto a 15-centimeter nail, which pierced straight through his steel-toed boot. He was in such agonizing pain that even the smallest movement was unbearable. But when the doctors took off his boot, they faced a surprising sight. The nail had never touched his foot at all. For hundreds of years, scientists thought that pain was a direct response to damage. By that logic, the more severe an injury is, the more pain it should cause. But as we've learned more about the science of pain, we've discovered that pain and tissue damage don't always go hand in hand, even when the body's threat signaling mechanisms are fully functioning. We're capable of experiencing severe pain out of proportion to an actual injury, and even pain without any injury, like the builder, or the well-documented cases of male partners of pregnant women.
Okay, that video goes on. It's good. It's fun and engaging video about pain. But yeah, we wanted to just highlight this story about the builder who had gotten the nail through his boot. Had anyone heard that one before or heard that kind of case study before? No, okay, yeah. So, and I think when I was looking through the article on it, like they were even giving him morphine, IV morphine, like trying to control that pain so much, and they were worried about how are they going to take off this boot. Like it was a whole big long process before they discovered that. So, again, the power of the brain, right? All right, so let's look at some of those key messages from the IASP that a person's report of an experience should be, respected. That's really in the main definition as well. Verbal description is only one of several behaviors or ways to express pain. And of course, we know that the inability to communicate doesn't negate the possibility that they're experiencing pain. And why are we having all these pictures of pain? So let's do a quick check-in. If somebody was to walk through their kid's messy playroom in the dark and accidentally step on some Lego that had been left out, what would your pain level be? You can just think about it, answer it. Hi, because you got the frustration on there too. What about eating a popsicle too fast? Getting a brain freeze. Yeah, that's a pain. Getting an injection. Sometimes we don't feel it. Sometimes it's painful, especially if we've got some fear around needles. Any of those pains not real? Any of those pain levels not real? Right? So just a kind of a way of explaining that. Pain is subjective, and there's no biomarker for us to be able to point to or to override somebody's description of their lived experience. And context matters. Working with patients with chronic pain requires a comprehensive approach where we're looking at what they're experiencing and what they're going through that biopsychosocial spiritual lens. New research and evidence-based practices emphasize that pain is not just that physical experience, and it's deeply connected to all of the things that are going on in that person's life. And that when we experience pain, those areas of our life also experience change, right? And unfortunately, that can set us up for some really difficult vicious cycles. I'm in pain, so I can't sleep, or I can't function socially as much as I used to. And when I'm not sleeping and I'm not interacting in joyful social connections, my pain is worse. So that's those bidirectional relationships that start to impact how we're looking at pain and how we're wanting to treat the experience for them. Let's see if I'm missing any notes here. Yeah, and then we just want to really help our patients understand that this is a complex, ever-changing, especially over time, process of contributing factors to that pain experience. And the sooner that we get that message to our patients, the more they're able to see that experience through that lens and kind of keep an eye and understand that. And we're not putting it off as, if it's not structural or if it's not this, more important cause of pain, then, it must have just been some biopsychosocial. And then that message, if it's brought kind of after the fact, doesn't land as well for folks. It's just not clicking. There you go. Okay. So the next one is about pain and nociception. They're being different phenomenon. So pain cannot be inferred solely on the activity of those sensory neurons. We talked about that, right? And this brain freeze we had talked about with the eating the popsicle too fast. Really what it is a message trying to tell us to change our behavior, to do something differently. And that's a great message. It's still a warning system. It's still there for our protection, but we can think of it through that biopsychosocial lens. And maybe it's telling us that we need to look at other factors in our life as well. And because we are bioplastic, these messages can start to sensitize over time. And although pain is usually serving an adaptive role, and that's what we're used to, especially if we've had a lot of acute injuries or illnesses, we're used to pain giving us like good feedback about what's going on at the body level. But if it does start to go towards chronic pain and these more complex factors interplaying together, it may have adverse effects on our functioning, our psychosocial well-being, and we don't quite see that change in the threat level, not accurately reflecting what's happening in the body. Right, the nervous system can get stuck in an overprotective mode. And we want to explain this, but also explain to our patients that this is good news. The fact that it can change one direction is also the meaning that we can change in the other, and that there are things that we can do to move that needle back down towards the safety level. Even if we're not always directly able to change what is happening in the body, we're able to change it through those other lenses to bring in more safety and get out of some of those cycles. So again, all of this is messaging that we're bringing to folks through self-management, and what it is helping them to retrain that overprotective pain system. And self-management is just an aspect of chronic pain treatment, right? It's not a replacement. It's not saying, oh, if all of those medications don't work, or if these types of interventions don't work, then you go to self-management. The research is really finding that if we're bringing self-management approaches in conjunction with other treatment modalities, those modalities, medications, interventions, physiotherapy, they're actually more effective. We're basically shifting folks from going from a passive, disenfranchised recipient or victim of their experience to feeling more empowered. They have more agency, more hope, and a little bit more sense of control. They're able to take an active role in managing their health and well-being, and it can look a little bit differently than what we maybe traditionally thought of for treating pain, when we're instead looking at, here's just a list. How can we help them with stress management skills? Because it's very stressful to live with chronic pain. How can we look at energy conservation, pacing, prioritizing, ergonomics, relaxation, mindfulness or deep breathing practices? How can we maybe make shifts and changes in diet, nutrition, hydration, self-compassion, being able to respond to ourselves with kindness and patience and grace when we're going through a hard time, engaging and prioritizing positive, joyful experiences, and finding a physical movement that is still feeling safe and tolerable, improve sleep. And all of these things that we're looking at is through achievable, not overwhelming goals that they can set, right? And really the list goes on self-management, but it's looking at their well-being through that holistic lens. And at first, maybe other domains of their life will shift before they notice that change in pain. And we can tell them that that's kind of part of the process and the journey. Unfortunately, with chronic pain, it has been so many factors that have piled on together that it may be a process of just a few shifts in all these different domains, and those tiny changes adding up to create an impact. So I'll pass it over to Jen for the next part. Oh, no, you have your own.
No, I'll take this. Okay. And I just wanted to mention, who has time to teach about self-management? I don't see too many hands. And I just wanted to emphasize that it's not all on you, right? What we're really hoping is that as primary care providers, that you support patients in knowing about self-management, right? Explaining that self-management can be helpful, in referring to our other allied health members, right? To pharmacists, social workers, OTs, PTs, nurses, right? And allow them to help support that message of self-management as well. You could refer to our self-management program. We love teaching about pain, and we find that it makes a big difference, right? So we understand that you can't take this all on your own. We are here to support you, and we would like you to support us as well, because I think when we have that consistent messaging, it goes a really long way. So next, we are going to be talking about communicating with patients, and we're going to watch a quick, yep, go ahead, you have a question.
Goal setting. Can you tell me about goal setting?
Goal setting, yeah, absolutely. So what we like to help patients do is set small goals, right? So we want their goals to fit in the SMART format. It should be specific, measurable, achievable, relevant, and time-bound. So if I say my goal is to have no pain, that is very tough, right? That is not a goal that we would recommend. But we want something that they could actually achieve and is like important to them. I want to be able to bring my child to the park once this week, right? And then we can make smaller goals to be able to achieve that, right? So we can ask our patients, what is your goal, right? Do you have something specific that you can't do right now that you want to work towards? I can't promise you that we're going to get there, but we can work towards it together. I'm going to try to help you achieve that goal, right? And that could be very powerful, right? And we teach our patients, right, small goals. And once we get those successes, we can move towards those bigger goals, right? If their goal is to return to work, I can't say, like, you're going to be able to be pain-free and return to work tomorrow. I don't have that power. But I could say, yeah, let's work on some skills that can help you manage your pain a little bit better, right? So we can dial that down. You can feel more confident to be able to do the tasks that you need in order to be able to go to work. You know, work with the OT to help you create a graduated return to work schedule, right? There's different steps that we can take to help patients feel more confident and to make those goals seem more manageable. Does that answer your question? A little bit? No?
Is it on? Oh, and I was also going to say too, like for a lot of patients, we see their goals are around this idea of safety and what can they do to feel more safe with their body. Sometimes I talk about it as like going to couples therapy with your body, and it's like your body is sending you, you're talking to you in this way, and you really don't like it, and you can't divorce your body. So what can you do? And maybe all we can do is change how we respond to those messages. Or how can we soften or create a bit more safety? So that's often a goal for our patients, is what can I do to bring more safety and positivity to my experience and to my life? So that's another offering.
So patient says, I want to be able to walk to the bathroom.
Walk to the bathroom?
Yeah.
Yeah, yes.
So how do you manage that?
Right. And so, you know, the patients will know, like Jen was saying, what is relevant, what's achievable for them. And you can take that and say, that's your hope, and we're going to put that in here. And what can we do to start first? And maybe first starting is like learning deep breathing so that when I'm walking, I'm breathing, or you know what I mean? So dialing it down to this really concept of how do I keep my nervous system within that window of tolerance to feel safe while it's going through whatever it's going through, those experiences and sensations.
So we're going to watch this video. Oh,
The stuffed animal woman.
okay. Thanks. Yeah. So I'll just, this is from Inside Out. I don't know if any of you have seen it, but it's a great movie. And in this section, Bing Bong is Riley's imaginary friend. Is that me? And is going through a loss, right? Riley is throwing out the imaginary friend's belongings, and there's two different characters. There's joy and sadness, and they're responding to Bing Bong. So we'll watch this, and I asked you just to take a look at the different approaches.
Oh, the stuffed animal Hall of Fame! My rocket! Wait, Riley and I were still using that rocket. It still has some song power left. Who's your friend who likes to play? No, you can't take my rocket to the dump. Riley and I are going to the moon. Riley can't be done with me.
Hey, it's gonna be okay. We can fix this. We just need to get back to headquarters. Which way to the train station?
I had a whole trip planned for us.
Hey, who's ticklish, huh? Here comes the tickle monster. Hey, Bing Bong, look at this. Oh, here's a fun game. You point to the train station and we all go there. Won't that be fun? Come on, let's go to the train station.
I'm sorry they took your rocket. They took something that you loved. It's gone. Forever.
Sadness. Don't make him feel worse.
Sorry.
It's all I had left of Riley.
I bet you and Riley had great adventures.
Oh, they were wonderful. Once we flew back in time. We had breakfast twice that day.
Sadness.
It sounds amazing. I bet Riley liked it.
Oh, she did. We were best friends.
Yeah, it's sad.
I'm okay now. Come on. The train station is this way.
How did you do that?
I don't know. He was sad, so I listened to what...
Hey! There's the train!
Oh, we made it! We're finally gonna get home!
What was the difference between those two approaches? Validation, yes. Empathy, yeah. Yeah, absolutely. That's what our patients need, right? Validation, empathy. And it helps us to be able to deliver a message and helps them feel that they could trust us, right? And language really matters. How we talk about pain shapes the patient's beliefs, trust, and engagement, right? So a patient with chronic low back comes in for a follow-up and imaging is normal. The clinician says, your MRI looks fine, there's nothing structurally wrong, so there's not much more we could do. How does the patient feel? Yeah, upset, angry, right? They feel maybe something's wrong with me, right? Right? The patient hears, your pain isn't real, I'm on my own, right? So in the same visit, we can use different language, right? Your MRI doesn't show damage, which is good, but it doesn't mean your pain isn't real. Chronic pain can come from a sensitized nervous system, and we can work on this together, right? The patient can hear something very different, right? My doctor, my family physician is gonna work with me and help me figure this out, right? That sends a signal, it sends a safety message, right? Same facts, very different impact. We also want to avoid stigmatization, right? Words like non-compliant, catastrophizing can make patients feel like it's their fault or carry judgment. It's really interesting. When I talk to pain patients, they're like, oh, I don't want people to think I'm lazy, right? They feel bad that they aren't able to contribute to their household, to go to work, right? And we don't want to add to that, right? And being careful with their labels, right? Not pain patients, right? Maybe the patient with chronic pain, right? that person is not defined by their condition. Oh, next thing. Active listening. So this is what sadness did well, right? Well, it really listened and was able to reflect back what Bing Bong was feeling. So what are some of the things that we could do when we're listening actively, or what are some of the ways that we can show the patient that we're listening actively? Right? We can let them finish their sentences and share how they're feeling, right? We want to be fully present in that conversation. Allow the patient to express their concerns, their frustrations without interrupting, right? We can paraphrase or reflect back to ensure that we have the same understanding, right? Without judgment and advice. I think this is really tough for us, right? As healthcare practitioners, we want to fix things, right? We want to be able to give them the easy answer, but sometimes it's not as easy as, one thing. Validation. So that came up right in the talk. So validation can build strong therapeutic alliance, can help de-escalate strong emotions and make problem solving and support possible, right? If the patient is saying the same thing over and over and over again, there might be a reason, right? They don't feel like they're being heard, right? They don't feel like they're being listened to, right? So validating that experience can be helpful.
So you are saying the patient is saying time and again that I'm having pain and all that.
Mm-hmm.
So should not we also reflect that what's patient's expectation about recovery? Because if patient is coming with chronic pain and with this mindset that I am going to be 100% pain-free, that is not going to happen.
Yeah.
Patient has to understand from the very beginning that this is not going to happen.
Yeah, and I think that's a great point, right? We want to be able to have realistic expectations of what recovery or healing can look like. But if a patient is feeling really overwhelmed or scared, maybe that's not the time to have that exact conversation, right? Maybe they need to be validated first. Hey, this is really complex. It sounds like you're dealing with a lot, right? And once they receive that validation and they feel heard, then we can slowly pepper in these different messages about, we might not be able to get to 100% recovery. You might not be pain-free, but that doesn't mean that you aren't able to engage in life the way that you want to, right? I've seen success in individuals, right? So again, just thinking about the timing that we have when we're talking to our patients. That's a great question. That validation helps patients feel seen, heard, and understood. And this is something that we hear often from patients, right? In our program, this is something that they really like. They're with people who experience pain, who understand what they're going through, and they feel believed, right? It really goes a long way. And there's different examples of invalidation, and we might not be doing this, we're hopefully not invalidating our patients purposefully, but there are some things that we could say that can feel like invalidation or make patients feel invalidated. So something just even as simple, like we talked about the scans, right? There's nothing wrong with you, the scan is clear. But they don't understand, like, why are they still feeling pain, right? So talking about that, right? Like we were saying, like even if, sometimes your scans can be normal, but the nervous system can play a part when you're continuing to experience pain. Right? Criticism, right? You're not resting enough. Oh, if you've lost weight, oh, you're too stressed, right? Those messages can be alarming to patients. So thinking about how we reflect some of our thoughts around the things that could be helpful to them. Comparisons, right? Patients compare themselves to other people all the time. They compare themselves to the past versions of themselves all the time. Right? It's not super helpful when they hear things like, oh, I just saw another patient. She was in a serious accident, even worse than you, but she's back to work now. Right? So that could be invalidating. Or that minimization, right? I'm sure the pain wasn't that bad. You should push through it, right? So that can be minimizing their experience of pain, right? Or, yeah. Any thoughts about this or any questions? Okay.
for the patient.
Do you want to?
Your best patient to accepting the program.
Do you want to go? Okay. We take a lot of people. Yeah, if they are experiencing pain over that 3-month mark, we will work with them, right? So if they are happy to attend our program, they understand it's a self-management program, that they're going to be receiving education, we will educate them. Like that is basically it. And we've opened up the referrals to not just primary care providers, but allied health. So anyone who is an allied health member in a Fraser Health program can refer to our program.
Just not non-cancer.
The weight is,
Actually, it's okay, sure. The wait time, we have 2 pathways to get to our program. So for direct referral to us, it's about a month wait time. And we have a nurse who calls all new referrals, sets them up with resources until they wait until their next available group starting that works for them. Or if they can't join a group, then they can just stay and do some phone coaching with the nurse. And then for patients who are already involved with the Jim Pattison Tertiary Pain Center, then they're coming to us. Their wait is maybe a little bit longer because they've already got wraparound care, so there may be 5 months or 6 months. And I was just going to say too, these slides that Jen has put together, it's really based on that program. It's like, what have the patients told us? The doctor that made the biggest difference for them. How did they talk to them, or the interactions that really triggered them or put them on a more hypervigilant state with some of these experiences.
Your referral form for Jim Pattison, it has either you can select intervention or you can select this self-management.
Mm-hmm.
You cannot select both of them.
So yeah, they will. It will be. So we're from the Fraser Health Community Pain Self-Management Program. The Jim Pattison Pain Clinic. It's not us, but we know about it very well. They have 2 pathways.
You guys have a different form?
Yeah, we do have our own form. Yes. It's short. It's like yes, yeah, no, it's short. I think it has just BPI. That's it. It's like one form. And for the Jim Pattison Pain Clinic, you're going to choose which pathway you want them to go to. They're not stuck there. So if you say, I want them to go to the interventional side, the interventionist will send them to us if they feel it's appropriate. So it's just, they're not stuck in any pathway. Yeah.
okay. Before we take any questions, maybe we'll just finish up the last couple of slides if that's okay? And then we'll
Yes, we
answer
will have
your
another.
questions.
That's right.
And so the last part of this is just autonomy, right? So patients are capable to make their own decisions around their own health and well-being. And in the program, when we're talking about self-management, there are many different options, right? There's many different pathways to healing. And so we want to emphasize to our patients that they know themselves best and they can prioritize what is most important to them, right? So maybe their sleep is impacted. Maybe that's what they want to tackle first. Maybe their mood isn't super great. That's what they want to tackle first, right? So a lot of different options. We want to provide information needed for the patients to make informed choices. And we want to encourage curiosity and allot time for questions and respect the decisions they make, even if it's not the choice that we would make. And another thing that is important is to meet the patient where they're at, right? So some patients might not be ready for self-management. They still are searching for answers and aren't ready to have that conversation yet. Some people might be able to do this full-fledgedly and really be into the whole self-management idea and be very independent in their own journey, right? So having the different options and giving those tidbits about, what is available can be really helpful. And, resist that writing reflex that we have. Do we have time for the case study? Yes? Okay, great. So on your table, you will see a case study. And it says there's a 34-year-old education assistant who was involved in a motor vehicle accident 6 months ago while commuting to work. She sustained multiple soft tissue injuries and was diagnosed with whiplash and migraine headaches. She has participated in physiotherapy, occupational therapy, massage therapy, and despite this, she continues to experience persistent pain that poorly controlled and reports significant sleep disruption. She has not been able to return to work. So this is different from what's on the table, right? Okay. So in a recent in-person appointment, she becomes tearful and states, "I've done everything I think I can, and I still have pain. Something must be wrong with me." So there's a couple questions there to reflect on and to maybe discuss with a partner, someone on your table, or what is your initial response and what would you want to do immediately? What are a few things that you would want to communicate to the patient? And you can practice a few sentences with a partner if you feel comfortable. And also thinking about how do these types of encounters impact you as a clinician? What are some resources that help you with complex patients, and what self-care strategies can you use?
Is the patient taking any medication?
So the patient is taking some medication. It's not important. Let's not complicate things. All right, we'll give you guys, we'll give the group about 5 minutes to think about it, and then we'll take it up, okay? Thank you. I will throw the questions back to you. So the first one is, what is your initial response? And what would you want to do immediately? Yeah. Sorry, I'm gonna
Go into an actor's role, just act.
just act.
What is the expectation from the patient?
Yeah, sorry, say that again?
What are the expectations?
Yeah, so we can ask some questions, right, to the patient, right? And before we do that, maybe validating their experience, right? Acknowledging that they are having a difficult time. Validating, normalizing, right? It is normal for us to feel overwhelmed when we're dealing with complex pain, right? When things aren't going as expected. We really want to build that therapeutic alliance and trust with the patient, right? So I think that's one of the things that we really want to do first, right? And we can learn about external stressors and other causes. What else is going on in your life, right? And we can go from there, right? What are a few things that you'd want to communicate to the patient?
You can do some screening, for example, do PHQ, CME.
Yes, absolutely.
So make sure how worse the insomnia, because insomnia can cause everything.
Yes, yeah, so I love that answer, right? So we can do some screening, right? PHQ-9, GAD-7. We could ask about their sleep, right? Because insomnia can impact our pain levels, right? There's some great CBTI groups out there that are available. Yeah, that's amazing.
Trauma history?
Yeah, trauma history is also important, right? We don't have to dig deep into their trauma background, but acknowledging that trauma can impact the pain experience and put patients at more of a risk of developing chronic pain. So that could also be a validating experience, right? Acknowledging that relationship. Yeah, absolutely. What are the stressors that are going on, right? Is there something that I could be doing to help you with that, right? Referring to our social workers for some assistance, if that could be helpful, right? Some counseling, if that could be helpful. Yeah. How do these types of encounters impact you as a clinician? Stressed, yes. Yeah, it's not easy. Yeah, it is not easy to work with pain patients. We definitely understand that, right? And encourage you to take care of yourself as well, right?
Do not put in any narcotic as possible. Do not place any narcotic.
Yeah, so thinking about how we're prescribing narcotics, whether that's appropriate. And we'll be talking about that in our 4th session, so hopefully you'll show up for that one as well. Are there any resources that help you to work with complex patients? Yeah, so social workers, mental health programs.
Our program.
Our program. Yeah. And on the rotating slide deck, we have other self-management programs that are available, right? So there's Pain BC, they have the Making Sense of Pain. We have Self-Management BC. We have Empowered Relief that is run through Pain Canada. The Power Over Pain portal. We talked about all these kind of resources during session 1. There's Pain Recovery, which does group medical visits and covers a lot of pain topics. English. And Self-Management BC does offer the programs in, Chinese, I think Mandarin and Cantonese, and then Punjabi?
Yeah, there's a few. They're
Yeah.
expanding.
Do you have translator?
So those programs are run in those languages. We don't have a translator, but we've had patients connect with translators or have patient family members attend some of the classes as well and help support the patients through this.
Well, and what about, I just like the plug, okay, thank you. On the self-management of yourself, right? Building the capacity within us as care providers is a way of building capacity within the system. And Jen and I know from ourselves, practicing these self-management skills, first of all, I can speak to it from my own lived experience when I'm interacting with patients, but it's also helped build up my resilience and my ability to cope. So just to remember when we're talking about self-management strategies for our patients, it's also for ourselves. So we can use these self-management approaches so that our nervous system is regulated and we're within the window of tolerance. And that's actually felt by our patients. They can feel how regulated we are, how safe and grounded we feel when we're interacting with them. If we feel totally thrown off and unsure how to answer them, they're going to pick up on that and they'll be adding to their sense of threat and danger and hypervigilance just from how our nervous system is regulated. So that self-care piece. Don't forget about yourself. Again, just a recap. I think these are our last couple slides. That biopsychosocial spiritual model is really what our patients are finding so impactful in understanding pain. That it is so complex and there's so many things that change when we have pain, and that those changes then start to generate pain in and of themselves. Changing, our muscle tension, our stress hormones on that physical level, how we're thinking, our cognitive health, our social capacity, the hope, our self-concept, those spiritual factors. And that having this integrated approach and lens to understanding and treating our pain experience is going to be so individualized. Makes it more complex and harder. We can't sit here and say, everybody just do X, Y, Z, right? That would have been lovely. But this holistic approach, and just a reminder again, this isn't replacing any other type of modality. This isn't saying, do the medicine or the physiotherapy, and if that doesn't work, then we're going to look at, cognitive behavioral therapy and acceptance and commitment therapy, mindfulness, spiritual care. This is going on along in conjunction with to strengthen and increase the efficacy of all those other ones. And just a reminder again that this is a message that will need repeated dosing. We call that knowledge is medicine, but it's not just going to be like one aha moment and they're done. Oh, got it, pain, biopsychosocial, the end, right? And they can know this in a logical sense or cognitively, but then they have to really integrate that knowledge so that they can apply it when pain flares up. And repeatedly over time, if they are able to integrate that understanding, respond to their experiences in a different way, that starts to shift their self-concept like we were talking about. They're going to feel a little bit more empowered and hopeful that they have a role that they can play with their nervous system. And that is going to be active. How active it looks is different for everybody. Some, it's that they really want to start walking every day. Some of them, it's just seated exercise, just deep breathing. Some of them, honestly, it's the biggest change is just how they talk to themselves when they're in pain. And so these are things that when we check in with folks a month after they've completed our program, what are they say that the messages that had the most impact for them? This is what we hear. The other big one, and you can change it to this slide, thank you so much, that we do here, we didn't have a lot of time to talk about today, is understanding the role of trauma, as Jen had mentioned, and that interplay between how does trauma experiences at any time on our life journey impact our nervous system, or that threat and danger detecting system. Remember, it's a learning and predicting machine, right? And so it's going to learn some things and start making some predictions differently after we've experienced trauma. And if you want more information or a little bit more learning on trauma-informed care, Jen has put up some QR codes here that you can scan. And there is the Pacific Pain Forum coming April 17th. That is a interdisciplinary pain conference, but this year is really focused on trauma. And actually, Dr. Gabor Mate will be a keynote speaker at this conference, which is amazing. So, yeah, that's it. I think now we're ready for questions.
Okay, so I think Prab is going to read off some questions from the Slido app. So if you have any questions, feel free to input it in there, and we will do our best to answer them.
Or just out loud.
We have one. Do your services accept phantom pain syndrome patients?
Phantom limb? Yes, yeah, we have had a few. We would do a treatment in conjunction with other therapies because for the community pain self-management program, we are just virtual and really honing in on that self-management holistic aspect. So, we wouldn't be doing mirror therapy or other things like that. But we have had great success with different types of phantom pain, yeah.
And we're connected with Jim Pattison, so if it is appropriate, we can help streamline some referrals over there to have that in-person treatment if necessary.
What is the scalability of psychotherapies as opposed to publicly funded interventional therapies, such as pain reprocessing therapy, that have shown promising effectiveness?
Okay, yeah, good thing I got to see that question in advance. So Jen and I had, if you heard in our bios, trained in pain reprocessing therapy, and this is a really promising and scalable modality because it can have really low overhead. There's no equipment that is needed. We can do it in person. We can do it virtually. The other nice thing about, pain reprocessing therapy, or we can call some of them like pain psychology approaches, emotional awareness and freedom of expression therapy is another one. They are being trained to nurses, physiotherapists, occupational therapists, and physicians. So a broad range of people who can help support that approach. And they're able to be doing PRT, from in the just one-to-one appointment level, but also already many health authorities in BC are starting to do group PRT classes as well. So you can go from, one-to-one patients all the way to a large group of patients getting this information. Some caveats about PRT, it's not for all patients. It's really the evidence and research is looking at it for more of that central sensitization or nociplastic pain. That being said, there's a lot of pain that does have some plastic element to it that PRT can help with. So it does help quite a lot of people. And then more specialized pain psychology approaches like CBT, the evidence does show that clinicians trained specifically at that level, like psychologists and psychiatrists, have better outcomes in those more complex trauma patients. They do need that higher level of expertise. I don't know if you guys want to add anything.
Comments about EMDR for pain.
Yep, I can answer, but anyone else want to answer? No, okay. We have had some patients come through our program really raving about EMDR as well. It is typically for trauma, right? A lot of the research has found that this is a way of kind of integrating and processing experiences through the subconscious. And it's a little bit less threatening for patients because it's not that maybe traditional talk therapy. They don't have to delve too deeply into the past history. In that way, folks sometimes find it a little bit of a more accessible way to help with reintegrating that safety signaling and that predictive system that we've been talking about. So EMDR, yes, we have heard great things about it from our pain patients, but it is, again, mostly aimed for trauma. Mind you, I would say most people who are living with chronic pain, especially if it's intense, even if they don't have trauma history, pain experience in and of itself is traumatizing. So, yeah.
Do we have any psychosomatic treatment, and where can we access it?
Anybody else want to answer? Psychosomatic, I mean, PRT. Yeah, PRT would definitely fall into that category of psychosomatic. Right now in Fraser Health, we don't have a PRT group, but Pain Recovery, they have a PRT series, so it is one of the resources that we put up in the slide deck. They have, I think it's a 6 or 8 week PRT group. So you would have to refer your patients to that program, and they do group medical visits around the topic of pain, one that is PRT. If patients are looking for the psychosomatic treatment, there are different counselors available who do specialize in that sort of treatment. And we like that framework as well because there's that mind-body connection, right? So anything that kind of looks at a patient from a more holistic lens can be helpful.
So, but where can you find these counselors who work on psychosomatic treatment or counseling?
Yeah.
Resources are really limited, to be honest. You spoke about Government. They have something called compassion inquiry counseling.
Mm-hmm.
That's it. What else? What else can be used for our patients?
Like when you go, if you're looking specifically for a counselor, like a RCC or CCC, when you go to the website of registered clinical counselors, you can put different filters to search. So you can search by location. You can also search by topic, and you can put pain, chronic pain. Now, the approaches might look differently. Acceptance and commitment therapy has a lot of research as being helpful for chronic pain. You might see some with cognitive behavioral therapy, also evidence-informed. Pain reprocessing therapy is gaining. Radical acceptance, EMDR, trauma. There's really a lot. And the thing that's difficult, just like we were saying, is that it's going to be a couple of factors of what's going to be successful for our patients. One is the fit with the clinician. So those types of therapies are relational based, which means that they have to feel safe and comfortable in relationship to that counselor or to that care provider. And, you know, just like we don't become friends with every person we meet, they might not necessarily click with every counselor they meet. Or they might think they want pain reprocessing therapy, but then they really want tapping or something different. So there is a little bit, and what can we do as clinicians? Just encourage our patients that it may be a little bit of a process to find the right clinician for them.
You're talking about the pathway?
The website for you're saying like when you look up registered counselors, of BC, then you can, just like if you're looking up the registered physiotherapists, you can look through geographical location or different filters. I don't know if you guys want to say anything else.
Is there any data on There is. It's not very common. It's very hard to find people that will do hypnotherapy for chronic pain. Where I trained at McMaster, one of the pain physicians there was the psychiatrist, Dr. Jeff Ennis, and hypnotherapy was a big part of his practice. If you're going to go look him up, you can't because he passed away. But there are some people in McMaster that are still using hypnotherapy for chronic pain. Do I know of anyone out here? No, I don't. I don't know if you both do.
Yeah, there's a occupational therapist, I believe her name is Zara, and I think she does incorporate hypnotherapy in her practice. So that might be a good resource to check out. Would you have a last name? Not on the top of my head. So if you give me a moment afterwards, I can check and let you know. Yeah.
And another one that's similar, but maybe you can find a little bit easier because I hear it from a lot of patients, is biofeedback. A lot of patients have found great success in biofeedback therapies. It's similar, but a little different.
And Dr. Pollock, what treatment do you offer and how can we refer patients to you? Thank you.
So at the Initium Center for Pain Medicine, the majority of what I do is musculoskeletal medicine and interventions. Very similar to what the Jim Pattison interventional group will offer, with the exception that our community clinic is not accredited for cervical epidurals. We don't do infusions. But if you have specific questions on certain interventions, you're more than welcome to ask. That'll also be the topic of our third talk, I think, in 2 months' time. So if you do want to figure out more or learn more about what's going on at my clinic or Jim Pattison, you'll have to tune in 2 months. Otherwise, Initium Center for Pain Medicine, we have our website there. And if you want, or if you have an idea as to what type of procedure you're looking for, you can always contact us or send the referral and we can try and answer and get back to you. We are on Pathways, yeah. Yeah.
As a follow-up question, how long on the average do you treat my patients before discharging back to me?
So it depends on the condition. So if someone has, say, end stage or say chronic back pain and they do well with interventions, for the most part, I'm more than happy to keep seeing them until they stop coming.
Do you support patients with GI symptoms, IBS, hypersensitive gut?
No.
We do. Fraser Health, yeah. And we have. Yeah.
And then this one might be for Dr. Pollock. Role of oxycodone and tramadol in chronic pain.
Sorry, oxycodone and tramadol.
Yes.
Yeah. So if you look at the WHO stepladder for analgesia, opioids are on there, right? Tramadol will be considered a weak opioid. If you were to start tramadol, it would be in the same population that you would consider Tylenol 3. Oxycodone, I don't recommend starting on anybody. It is more addictive than the other medications. And at some point, there is a chance that it could be taken off the market. So when I do start people on opioids or prescribe opioids, it's usually Tylenol 3, Tramacet, Tramadol, Tapentadol, very rarely methadone, but Suboxone or Butrans patch, morphine, hydromorphone.
Would you prefer the morphine patch or
Sorry?
the patches?
The Butrans patch or the fentanyl patch?
No, sorry, the skin patch. Buprenorphine.
Yeah. So for some,
Instead of, for example, Tylenol 3?
it depends on the type of pain. So I would, so if it's chronic pain, so if it's essential sensitization or chronic widespread pain, you may be able to manage them with Suboxone. I've had good success with that, with TID dosing. Alternatively, if they have trouble taking tablet 3 times a day, then I would switch to the patch.
Maybe you keep it.
Okay, I'll keep it.
Is there one point triage center where people can refer to, and then that referral can be distributed to whatever person that fits with that patient?
Not at this time.
No, we don't have central triaging.
Sorry, I was just going to add to that, George. And I think if you refer to the Jim Pattison Pain Clinic, in your referral form, you do have the option of a medical visit for a specific intervention, but also the group visits. I'm not sure if that's what they were getting at in the question.
No, I think at least if I interpret it correctly, it's like there is PMBC, there's the stuff through Fraser Health, there's yourself, there's so is there one place where you can refer to, and that person will then sort of triage, kind of like how you have with the BC Cancer. You refer to BC Cancer, and then they triage to the therapies that are appropriate.
Yeah, not yet.
But Pain Care BC, it's part of PHSA. They have some kind of high-level people looking at it and identifying that would be really helpful. Just kind of feasibility and funding at this point. But it is on the radar.
We don't have any more questions on our Slido, but does anyone have any other questions? I can come around with the mic. Okay, then, if you have any additional questions. Oh, sorry.
Yeah, I think we talked about like EMDR can be helpful for those patients, helping them understand that their trauma can have a role in their pain processing can be really helpful, and opening up the conversation to whether they are, amenable to something like counseling or, talking to others, like a psychiatrist might also be helpful, right? So, oh, they don't speak English. Yeah.
Another thing they can look into on their own in different languages is skills in mindful self-compassion. I don't know if you've approached that, but there's a lot of research on the power of skills in self-compassion. They've even, Dr. Kristen Neff looked at soldiers who had been deployed overseas and seen action and come back with symptoms of PTSD. As their skills in self-compassion increased, their PTSD symptoms decreased. And that's kind of getting a lot more spread, and probably you could find resources online in a variety of languages.
And maybe the Pacific Pain Forum is something that you'd be interested in attending, because trauma is a big topic during that forum. Yeah, go ahead.
Dr. Perry, in the emergency room, we deal with many science situations. Like, for example, a patient has chronic pain, osteoarthritis, so they can't do ER many times. They say, oh, no, I tried Tylenol, number 3, try anything, pain medication, muscle relaxation, and also even like they say, Percocet, or they're not working. So I'm the only working whenever I come to emergency room. Then the doctor just give me the hydromorphone. So do you think what can do for this kind of patient? So patient, if they say no any medication working, I just need hydromorphone, IV or the IM or the PO. So what do you think to do for this patient?
So what would
It's a challenge.
It's very challenging, because they're in there looking for one thing. They're looking for their hydromorphone, whether it's IM, IV, PO. Right? They're not interested in looking at anything else. And it's one of those things where I think Jen may have mentioned it with like sort of goal setting is like readiness for change. So at what point are they going to be ready to accept that, look, I can't be managing my chronic pain by coming into Emerge because I've got osteoarthritis. I guess it also depends if it's knee arthritis and they're waiting for a knee replacement, like that's different, right? Yeah. It could. Yeah.
Pending for because the time to see the surgeon is long time with. So
yeah.
they did give me some orthicode already, but they stronger pain medication, like hydromorphone. You need to give the patient because I'm sure this type of patient already has truly have pain, but at the same time, I'm sure they have narcotic addiction already, or even pain. So if you give them more, hydromorphone, they will be everyday pain.
They're going to be coming back, right? I think that's where you sort of take that hard. I mean, if I was in your shoes, I would take that hard stance and say, look, no, we're not going to do it.
That's easy to say.
That's easy. It's easy to say. It's easy.
Right, and also patient keep going.
Yeah.
But I know it's a challenge. It's not 1 week. If you give the patient, then the next time he will be keep going, coming.
Yeah.
But you don't give the patient will become right. Will be now you're not happy.
Oh, 100%, yeah. And it's one of those things where it's like if you're having a good day and you might feel generous, you might give them a script, give them 10, send them out, right? Or if you're feeling like you're going to want to be a little bit more, you want to stick to your guns, you might, put up a little bit more of a fight. But in what would the guidelines say for osteoarthritis and chronic pain? The answer is no to opioids. Yeah.
And can I add too? We have some physicians who say, go to self-management first, look at self-management first, do their program first. I also worked at St. Paul's and they say, before you get neuromodulation, do self-management first. And Jen and I are used to folks who are like, oh, I don't want to be here. Like, this is not for me. I just need my meds. I'm just doing this to check a box off. And I cannot believe how many patients come after us and say, wow, I didn't understand all these other things were going on for me. And I'm also personally just really impacted by how many arthritis patients come and tell me, I had no idea my childhood trauma was impacting me. And so the role of arthritis and trauma is really, really strong, actually. And I hear that from patients a lot. So again, just to bring some of that experience.
Thank you, Jen, Julia, and Gary, for sharing your expertise. So in closing, thank you to our working group and our presenters, all of you, and our SND team for putting this event together for us. See you at the next one.